as our chairperson, and Neelam Mohan ji to bilkul favorite speaker on every issue of gastro in all over India as our faculty today. And I'll request Dr. Mukesh Dhankar to please start the proceedings. And सर को इंट्रोड्यूस कर दो या सर उनको चेयरपर्सन को और मैडम जैसे आपने प्लान किया है मुकेश करो प्लीज.
Right, sir. So,
Mukesh, good evening.
sir,
Dr.
good evening.
Anupam. Yeah.
Sir, good evening, sir. Welcome, sir.
Thank you very much.
हाँ
So,
सर.
go ahead, sir. Go ahead, sir.
हाँ, आलोक जी कुछ कह रहे थे आप? Okay, Mukesh, good evening
Sir.
to Upendra, Biswal and Neelam.
Good
All
evening.
of you.
Good evening, sir.
Thank you very much for joining us. Please go ahead, Mukesh. You should start the program, please.
Right, sir. So, officially, I would like to start now. On the behalf of Delhi IAP and Institute of Child Health, Sir Gangaram Hospital, I would like to welcome all the respected teachers, dear delegates and students for this webinar on constipation, what's new. So, for this, we have our chairperson, Dr. Biswal, respected person and a dear friend of ours. He's a professor in the Department of Pediatrics at Kalinga Institute of Medical Sciences, Bhubaneswar. He's also an Central EB for 2024 from Odisha. He had been General Secretary of Odisha State Branch from 2021 to 2022. He has been EB for State IAP in 2002, 2008, 2009, and 2016, and has many national and international publications and has a teaching experience of more than 18 years. So, welcome, sir. I would just request you to say a few words before we move further. Biswal, over to Biswal, sir.
Thank you, Dr. Mukesh. So at the outset, I am very much thankful to Delhi IAP, especially Anupam sir and Alavandre sir and Dr. Mukesh for giving me the opportunity to chair this webinar. So, first of all, it is my great pleasure to welcome Dr. Neelam Mohan, so the Senior Director at the Department of Pediatrics, Gastroenterology and Hepatology and Liver Transplant in Management City. So Dr. Mohan is a distinguished leader in the field with the numerous accolades for her groundbreaking work and dedication to patient care. And her expertise has transformed countless lives, particularly their youngest, most vulnerable patients. So we are honored to have here today to share insight and advancement in the field of about the conservation. And he is credited a good many number of awards and achievements like Bisra Award, Award, Distinguished Teacher Award by National Board of Examination 2021, and established first department of country in pediatric gastroenterology, hepatology, liver transplant. Madam also have posts like now he is President Commonwealth Association of Pediatric Gastroenterology and Hepatology Nutrition, Academic Council members of Indian College of Pediatrics, advisor to PMJY, Pradhan Jana, advisor to National Board of Examination of Pediatrics. And Madam also have previously president in Indian Society for Pediatric Gastroenterology, Hepatology and Nutrition, an executive member for Central IAP for 2023. And Madam has more than 1,000 presentations on national and international level, as well as more than 120 industry publication with credit. So I welcome Madam to today's webinar. As well as I also welcome our beloved past president, Dr. Upendra Kinjwadekar, and who is the consultant in the Apollo, as well as Kamlesh Mother Healthcare in Mumbai. And during his tenure, he done good work, and which is what which did not come before also. And now I also the International Pediatric Council member for NCD for 2023-25. And very much honored to welcome sir to as a moderator to for this session today. So now I'll invite Dr. Neelam Mohan to deliver his presentation.
Sir, I would just
Uh,
like to interrupt. I would like to request Dr. Upinder Kinjwekar sir to say a few words before we move ahead, sir. Sir, over
Yeah,
to sir.
Mukesh
good
also
evening.
upgrade Arjun Maria as a this thing. He's a pediatric hepatologist.
Right, sir.
Uh,
Okay, right, sir.
Good evening, Delhi. So, all my respected dear colleagues, all not only from Delhi, but I'm sure across the country, those who have logged in for this great academic initiative started by IAP Delhi, my great colleagues. Now, of course, when Dr. Anupam Sachdev, my dear friend, as well as past president of our IAP, called me to moderate this session, I immediately said yes, because for all these academic ventures, I'm always willing to be there. And it's a great opportunity to connect with our friends back here. So Dr. Seba, thank you so for that kind introduction. He's colleague of 24 EB, and I have my 23 EB colleagues also. Dr. Neelam Mohan, the speaker today itself, I was fortunate to be with her in 23 EB, and of course, Dr. Lalan is here, and Dr. Kaushal, the current 24 EB member. Dr. Mukesh, always a great friend. Dr. Lalit Bendiratha has just logged in. Welcome, sir. And of course, Dr. Alok Bhandari, Joint Secretary, Liaison last year, worked with him for many years, but last 2 years, especially as a part of our EB board. So a great opportunity to connect with all of you. I'm sure now this is a good time in Delhi. Everything must be cooling down. I hope and pray that the weather really turns around much before 4th June in Delhi itself. So and it's a great topic that you have chosen. Very important practical topic of constipation. I think all of us have seen in last couple of years the amount of patients of recurrent abdominal pain have increased tremendously, especially since 20. So it's almost 4 years since COVID struck. But then one of the commonest cause of recurrent abdominal pain, once we go into the dietary history, is nothing but constipation. The commonest cause across the country. While speaking with pediatrician colleague across the country, we have always found that it is the cause, and it comes to at various ages. The precipitating factor could be different, but you talk about infancy, you talk about young child, you talk about adolescent, constipation is there, and I'm sure the adult colleagues must be also seeing the similar pattern. There are many factors. None of the medical illnesses are attributed to a single factor. All are multifactorial, and I'm sure Dr. Neelam Mohan is going to enlighten us not only about the current concepts about it, but what is a proper therapeutic management guideline that all of us need to follow, and at what point of time really we pediatricians, the general pediatricians, should say, yeah, this is a time to actually take opinion of a gastroenterologist. Otherwise, most of us should be able to manage, as all of us know that 95% of the time it is the functional constipation that we come across in our day-to-day OPD. So having said that, let's listen to Dr. Neelam Mohan, and once she finishes her deliberations, we'll come back to little more with more interaction. Over to Dr. Neelam Mohan. Thank you so much.
Thank you so much, Upendra. And I think it was our pleasure to be an EP with you, a highly learned person. And we did together the nutrition module. And only I would do is to introduce him and shut up and listen. That was just before he became the president. And the energy levels which Upendra has, I always MJ about it. And it's been really nice with the school project that he started. It really clicked, everyone. And thank you so much, Upendra, for this wonderful idea, which turned, and I still get a lot of people to compliment about it. So with the permission of the chairs and the organizers, I would like to share my screen, and kindly let me know when it starts showing.
From my side, Dr. Lalit, good evening, everyone. Before Dr. Neelam, you can start. Dr. Bhupender sir, namaskar sir, welcome to Hot Delhi. And Dr. Sabrajan Biswal, and hello, Dr. Neelam.
Is it showing? Is it showing?
Yes, yes. Yes,
Okay.
yes, it will.
Right. I think it'll get as the presentation, and I can request them to just pin me so that I'm seeing so many people. I don't know how to make that. Okay. Okay, so the topic that was, thank you, Lalit, for that joining us, and it's nice always to see you being so academic. So the topic that is given to me is not just constipation in children, but the title says, What's New? So there are a couple of things which I'm going to talk about more than the slides. And we all know when we talk about constipation, there's a change in the definition. Some like to call it 2 weeks or 3 weeks. Having said that, the general consensus is Something which goes beyond a couple of weeks is what we're going to call it as chronic constipation, and it should be sufficient to give distress to the patient. That's the right way, because sometimes if you look at the Rome criteria, they just don't look at the numbers. They look beyond that. So just like in diarrhea, we also talk about the consistency. Similarly, in constipation, we talk. So as Dr. Upendra talked about, with this, imagine 40,000, 45,000 pediatricians. It is said even in India, the general visits to a pediatrician is 3 to 10% are nowadays with constipation. And if I look into a pediatric gastroenterology practice, I mean gastro without hepatology, then predominantly 1 in 3 GI cases turn out to be functional constipation. And the mean age of onset is the time when you're getting toilet trained, close to 2 years of age, and the peak prevalence is the same preschool age. So the Rome 4 criteria, which also talks about the global prevalence, which is seen with functional constipation, is to the tune of 15% globally. So I said 3 to 10% because the data that we talked about, but it could go as high as 15% globally in children. And the prevalence, as you can see, is at its peak in infancy and up to 2 years, and then subsequently 13%, and then goes down. And toilet training has a lot of impact to that. So when I talk about the diagnostic criteria, what I want to impress to you with this slide was not just the number. So Rome criteria, to call it functional, chronic, I said, was a couple of weeks, more than 2 weeks. But for the functional constipation, we say more than a month, 2 criteria. And this criteria could be in infants or in children slightly different, because in infants and toddlers, you could have hard or stool retention, large diameter stools, fecal mass in the rectum in the toddlers, or incontinence and large diameter stool that obstruct the toilet. Similarly, in children and adolescents, besides all those factors like painful retention, large diameter mass, incontinence, we also like to add this line: the criteria are insufficient for us to call it IBS. Now, this is very interesting part that I want to talk about is, and hopefully someday, I'm giving a talk somewhere next week, 7th, 8th, and I'm very impressed with the organizers to have chosen a topic which says, what are you going to expect in Rome Fry criteria? So what we are going to expect in the Rome Fry criteria is the gut-mediated access that we are talking about. So the risk factors is, we now know, I've been trying to tell you about toilet training. So if the child had a stressful life event, whether it is related to school, whether it's related to home, whether it's related to child abuse or psychological issues. So just imagine what I'm telling you. I'm saying that sensually mediated factors are going to have impact on the nerves, which are going to affect your gut. So what are the other gut-mediated factors? That's your diet, that's the physical activity, and now we've marched on to say abnormal microbiota. In adolescence, factors like sleep, etc., is included in the stressful life event. Before I go further, I think all of you need to understand this diagram, that when I or anybody wants to pass a poo, so first, the lowermost part is the rectum. So we have the sympathetic and the parasympathetic stimulation there. That means when the feces come in the rectum, Then there is a stimulation of the parasympathetic controlled defecation reflexes and the stimulation of the local defecation reflexes. So what does one do? They go to the toilet and you open up your external anal sphincter, and once you open up, automatically the rectum contracts and the stool comes out. So I repeat, you get the stimulation, local nerves are increased, locally you can open the anal sphincter external, and then there is a stimulation of the rectum. But imagine that this what we are talking about, if it goes wrong with the toilet training, then it's going to have an impact on the way you're going to do. So this voluntary signals, which I decide to go, that is the one which stimulates the relaxation of the sphincter, and that's how the functional, the passage of the stool occurs. So either when the child is in the phase of toilet training, there's an intentional withholding of the stools. That means you don't open, or you don't contract, or you rather contract the external anal sphincter. Having said that, sometimes you can have a slow transit. A slow transit is the time the bubble takes to move down. And this transit can get further slow if you're on a very high fiber diet. The luminal content normally should be an ideal water and an ideal fiber to get the right push into the lumen. And the last part is the dyssynergy, is what I'm saying, what's new. And this is what I'm going to talk about, what's new that I'm talking. You have heard people saying the luminal content and the withholding. And now I'm going to talk about the dyssynergy and slow transit. I'm not going to talk too much, but dwell a little bit about that. So when the child has stool in the rectum, and then the child wants to pass stool, but the stool is hard. So the child tries to open it, and it's a painful defecation. So the child doesn't want to open the external sphincter. So there's a voluntary withholding. The stool stays back. It gets further dry, and there is reabsorption of more fluids, and it gets further hard. And then once the stools get hard, it takes more space in the rectum. And to pass it, you will have more pain to get it. So that was the thing. And what about the alteration in the gut microbiota? So we've now shown that the alteration in the gut microbiota is a very important pathophysiological mechanism. And you find certain species less abundant. These are supposed to be the good species, the bacteroids, the lactobacillus, the bifidobacteria. This get less abundant in the patients with functional constipation compared with healthy controls. Similarly, this microbiota change may be questioned. Upendra can ask me, Neelam, is this because of constipation that the gut microbiota change, or because of the change in the gut microbiota, this constipation happened? In short, what he wants to ask me is, which came first, the chick or the egg? So it's a little difficult question, but having said that, a lot of studies have shown that if you use the poo into another individual who's already been constipated into, say, another mice, then there's a chance for that poo, that mice, to get constipated. So it does have an effect on this and the diet. So how does your microbiota change? Why are you going to talk about the diet? So actually, when the school program we are doing, and we're showing that in 2 major meals, you should take 50% vegetables and fruits in the 2 meals, excluding your 3rd meal, which is the breakfast and 2 snacks, is what we're trying to harp about, that this healthy diet, the vegetables, fruits, fiber, that is going to improve your gut microbiota, and this is going to delay the colon transit and then lead to further gut microbiota communities, etc. Now, what are the organic? So I said I'm going to talk about the functional constipation, but say, depending on the, whether you are a physician or an expert, whether you're a surgeon or a gastroenterologist, you can go from 5 to 15% of the cases you might find organic. So what do you mean by that? Either there's an anal stenosis, the anus is placed anteriorly, so the angle is not formed, and then neuromuscular causes like Hirschsprung's disease, intestinal neuronal dysplasia, pseudo-obstruction. What I mean by that is the GI motility. So that, or the spinal problems like tethered cord, myelomalangioceal problems, patients with CP and then neuromuscular issues that they deal with, or the metabolic and endocrine factors like calcium, hypercalcemia, hypothyroidism, diabetes insipidus, certain medications you may be on, like iron, NSAIDs, and chemotherapy drugs like vincristine, opiates, and antidepressants like tryptamar and all can give rise to constipation. And of course, I can go on and on, but certain syndromes like Down syndrome, cystic fibrosis, milk protein allergies, etc., can also give rise to constipation. So it's not all about functional. This could also be anywhere from 5 to 15%, depending on your practice, that you may find an organic cause. So let's remind ourselves the symptoms and the signs. So the age of onset, if you find the baby younger, a neonate, less than 1 year of age, then it's more likely that you need to be spending your utilize your energies into ruling out an organic cause. So a delayed passage of meconium beyond 2-3 days, or absence of withholding, absence of soiling, these, and then bladder dysfunction, especially when you have urological colleagues refer me a lot, because bladder bubble dysfunction, and then this nerves, and then you have certain extraintestinal symptoms that you're talking about, and no response to conventional therapy, do rule out an organic cause. So not only the symptoms, what about the signs? You can find features of hypothyroidism, coarse facies, cold, surgical scars, perianal lesions, features of sexual abuse, bilious vomiting, abdominal distension, ileus feature, pseudomotility. So the obstruction, you can see in the pseudo-obstruction, the movement of the bowel can be seen in that, a patulous anus, an anteriorly placed anus, absent anal wing, or cremastic reflux, spinal lesions, low limb weakness. This all will make you think about an organic cause. So generally in an examination, you do the general examination, paropton, anal position, perianal examination, and not always all. Often you may decide to do a perirectal, but even if you don't do the perirectal, don't forget to look into the anus and the perianal region, because you need to look into the Fouché, what is the size of the anus, position, and a good examination. And this thing can help you to pick up lumps also sometimes. And sometimes you go in for a barium, and that is, this is utilized, for example, in diagnosis of Hirschsprung's or detecting anal mass lesions, and then you're going for it. And then the lab investigation. So I want to remind my colleagues that most of the guidelines say that you need not do this, the ISPGAN, the NASPGAN, without alarming signs. It's not mandatory for you to do a workup. Having said that, only cases where you get into refractory cases or you have other features, then you need to rule out the thyroid, celiac, vitamin D, hypercalcemia, milk allergy, etc., that you can think. And the Indian guidelines say that in intractable or challenging to treat constipation, you could do a thyroid and calcium. And these are the Indian guidelines to say about it. And radiography routinely is not recommended for all. It's to look for it. But during COVID, it became like, generally you were avoiding perianal or perirectal examinations. And that was the time that you were doing. But then we are now moving back to the general normal system that we were going with. And sometimes the patient may be too obese and you're not able to do an examination, or the patient is a lot apprehensive, there's psychological factors, some abuse, and neurological issues, in that case, you might decide to go in for a X-ray in then. And then when do you want to do for a barium enema? When you're suspecting a Hirschsprung's disease, or then you look at the how much you look for, is there any narrowing zone, or you look for how much time it take for the barium to completely clear in the colonic images. That also is very useful. So when you do a barium enema, you always ask for a late image films too in those cases. I think we are coming to the end, and I thought let's break the monotony with a case. So a typical case, 5-6 years old, who came, centiles were okay, but the constipation was going on for more than a couple of years. The patient had seen several doctors. Whenever they gave any stool softeners, the stools were getting very loose. So the mother would end up stopping it, but then it would come back. So the child was also investigated, and outside some vitamin D was low. There was a thyroid and a calcium, which was okay. A little lower hemoglobin, and there was a small fissure. So when you find a fissure, it rules out Hirschsprung's disease. Fissures are typically seen in functional constipation. And on the right side, I've shown you an X-ray where you can see a lot of stool, not only above, but if you concentrate, the rectum also shows a lot of stool in that. So this is a case of a functional constipation with impaction, because I can see a lot of stools in the rectum. There is an anal fissure. It's been going on for a couple of years. So that's what you look. So how will I treat it? I'm going to first disinfect that stool, which is a hard lump that is in the rectum. And then I'm going to put the child on a maintenance. The drugs that are available are osmotic, like, lactulose or polyethylene glycol. Sometimes you like to use the stimulants like the glycerine suppository or picosulfate or bisacodyl, and other drugs that are available is the mineral oil or the magnesium, the fibers, the enemas, phosphate, etc. So this is the armamentarium that you have for treatment. We all know the doses, just reminding ourselves that polyethylene glycol in disinfection, we use 1 to 1.5 gram per kg, followed by maintenance from 0.4 to 1 gram per kg, and lactulose is 1 to 3 ml per day. And mineral oil, same dose. Bisacodyl is a small 5 mg. Senna you should shy away from. And usually the Babaji churans contain a lot of senna, and that can give rise to idiosyncratic hepatitis. So senna may not be directly available as senna in churans. It may be in some other leaves form, and you can Google and realize what it is. Also, dear colleagues, remember what brand you're using, because different brands have different concentrations. So there's no point. Learn your brand and ensure that you're using either, it could be as low as 6.8 or as high as 17.7 or 8 and 13. So know your brand, what you are going to prescribe for that. And so in this case, I'm going to give disinfection for a higher dose of 1.5. And then I'm going to talk about the maintenance. And then I'm going to talk about the diet and the fluids. So the junk, if you had heard about the SSS school projects that we were talking about, less bakery, less junk, more vegetables, more fruits, reduce the milk, no beverages, good diet, fiber in the diet, an average at least 8 per fly plus 3, 4, and you want a pediatrician to tell you or a dietitian to tell you, whatever, ensure that your fluids, the liquid water that you're taking is adequate. I mean the patient. And then know this, I did the same thing, but unfortunately the response was not great. This patient had also received the adequate doses before coming to me. So overall, 3 months, the response was not great. So now I'm going to call it refractory constipation. So bingo, what's refractory constipation? Refractory constipation, if no adequate response to optimum conventional treatment for at least 3 months. So now I'm going to talk. I mentioned to you initially that when you look into the various factors, you talk about the luminal content, about the withholding, about the transit, and then I said about the dyssynergia. So dyssynergia could also be a cause for functional constipation. And besides dyssynergia, which I'm going to just talk to you about, the other causes could be premature withdrawal of the medication, lack of education of parents, lack of toilet training, stubborn baby, wrong diagnosis, motility disorder, pseudo-obstruction, slow transit, etc. So I thought about anal dyssynergia, and then I moved on to an anal manometry. I asked them for that. So what is anal manometry? Anal manometry is a system where it's a small catheter which you're going to put below the anus, and in the catheter you have like a balloon, like a condom attached to it, and you can fill it with water in it. There are different solid state or a water perfused. We use the water perfused. So when I put into that balloon water, it distends to say 5 ml, 10 ml, 20 ml, 30 ml, 40, and that would give rise to a size that I'm going to imagine what it is. So what can I look into it? I said to you that when the external anal sphincter is, when you open it, then automatically the rectum contracts. So A, I can see the nerves, how they are moving. B, I can see when you get the sensation. C, I can see what's the squeeze. In neurological cases, the squeeze will be bad. And most important, I can see the rare. That means how do you discuss the opening and the contraction? That's what rare is going to be about. And I can decide whether the pressures that is needed to open up the sphincter, was the pressure adequate, or the pressure given to contract the rectum, was it adequate?
नीलम थोड़ा पानी पी लो.
New house, no servants around. So this is the anal manometry advantages, and my purpose was not to look into the Hirschsprung's disease. My purpose was to diagnose dyssynergia. So when I look into this, so first is the recto-anal inhibitory reflex. So I mean, not that I'm going to teach you, but just like when you on the first side, on the left side, you can see that the red zone has gone less. That means the rectum is, when it contracted, the sphincter tone reduced. But on the right side, I'm showing that the red part did not decrease. So that means the anus did not relax. And then again, on the left side top, I'm showing that the propulsion was not adequate. You know, the colors were same. But on the top right side, I'm showing that the pressures increase. You know, the upper part, which is blue on the left, has become orange. So that is good. And inadequate anal relaxation and paradoxical anal contraction. So the lower part, I'm showing that instead of red, it's become black. So instead of opening, the child is actually contracting. So this makes it very useful because I can discuss with the parents and then I know how to work it. I do the biofeedbacks, 2 to 4. We were the first one to present this paper, a large series. And now there are more papers coming up with children on this. And as you can see, I'm just trying to show that how the rectal pressure, which was blue initially, went on in the last diagram, a graph which went up, and the anal pressure went down. So I want the anal pressure to decrease and I want the rectal pressure to increase, which I could do. So these are specialist tests: the anorectal manometry, EMG, myography, difficography. This is my bread and butter, dear colleagues. MR difficography, colorectal transit, and the rectal biopsy. So what we do is not what all surgicals always tell you. So very interestingly, we used to always do a surgical biopsy. So you need to take them into the theater, you need anesthesia, you need a full thickness biopsies. So now we've come out with different modalities where endoscopically we are able to get the muscle layer. And I've done this in 5 patients, fortunately, where we are able to get, so we take 4 biopsies and we look at the muscle, whether the ganglion cells and the ACTH esterase is there or not. So you could save all that and diagnose Hirschsprung disease also through this. And this is just MR difficography, which tells me, are my muscles atrophied and they are not working in some regions? Like in this report, it says severe atrophy of the external inner sphincter. And then how in MRI, I'm going to see how it's going to contract and relax. And so these were just to not for the run of a mill cases, but I just wanted to emphasize that that's the new baby on the block that we are talking about. And that's the new thing we are talking about. And the new thing that we are expecting the Rome criteria 5 to change now. And so to sum up and give time for Upendra to moderate the questions, I would just sum up with some key messages. Functional constipation is the most common cause of constipation in children. They need good history and a physical examination. Look for the red flag signs like failure to thrive, delayed passage of meconium, abnormal bowel habits since birth, sensitivity to cold, fatigue, dry skin, pallor, mouth ulcers, perianal tracts, skin, spine deformities, anal positions abnormal, fissures, perianal tracts, fistula, and spinal raphism, all these features, reflexes in the lower legs. Constipation can give rise to a plethora of presentation, and I did not discuss with you. I just said that the child is constipated, and Upendra just opened up by saying it's a very good common cause of pain. But dear colleagues, besides the constipation and besides the pain, the plethora that I'm talking about is the psychological factors that the child, because there is so much of farting, there is distension, loss of self-esteem, the child gets into a conservative state, there could be abuse secondary to that by the colleagues, and the child becomes introvert. They may not like to play. There is the UTI infection, urinary tract infection. You must rule out constipation, and I can go on, but you must do an examination and understand when you need to disimpact and then go for maintenance. If you're not happy with the therapy, with a good response in 3 months, then you call it refractory and investigate by sending to an expert. However, when I said maintenance, I'm not saying that in 3 months you need to stop the therapy, and if you're not able to stop, that's refractory. No, I'm saying if you're not getting an adequate response, then you call it and you're not able to taper it down. But the maintenance can go as high as 6 months to a year, and some of them with the slow transit and others may go on for a longer time. Educate the family about the diet, the behavior, the toilet training, etc. And these modalities that we use like manometry, it tells us the sensation when I can get it, what is the tone, what are my reflexes, how's my squeeze, how's the sensation, do I open it properly, is there dysenergia, what are the motility studies, the colonic transit time, that is an expert thing which I've not dwelled. So they are for the slow transit, the myography, the pseudointestinal, the transit time, the biopsies, the balloon expulsions, the MR diffocography. That's for the experts, but you should know that we can do. And I'm happy that we have a lot of fellows working, around 6 fellows, and that's the team with which I work. And thanks to all of them and the patients who trust me for their children. And thanks again to IAP Delhi for this opportunity to me.
It was wonderful, Dr. Neelam.
Okay. Sorry.
Yeah.
We have 2 big experts, Arjun Maria and Sham Sundar Meena, invite their comments also.
I tried to stop sharing it. Is it stopped?
Yeah, you can stop sharing, Neelam.
I did not. So has it stopped?
Yes.
Okay.
So great to have, and Neelam, it was a wonderful, insightful session, and you very rightly touched upon not only the conventional aspects of constipation that is usually talked about, but the latest concepts also. You started off on a very positive note about toilet training. I think that was very important, and I feel that is one stage where if we go wrong, you can definitely end up with constipation. So my humble plea to all pediatrician colleagues, when the parents ask us about toilet training, what is the right age, I think all of us need to be on the same page, should understand that there are not only one single reason, but we need to know about the child's readiness. So there are physiologic reasons like myelinization of the pyramidal tract to the sphincters takes place by 12 to 18 months. So please do not attempt before that time. It's extremely important to have the developmental signs. If the child is showing, that means he's the ability to ambulate to the toilet, child can to pull clothes up and down, if he can do that, sit at one place, dry by most of the times for several hours during the day. It's very important. Entire family needs to speak in one language. So use one word, either tatti, potty, poo, whatever you say, but not every person should speak in different language. One word for the passing of the tatti, that is should be happening. And behavioral also, I think we need to talk up to them. They have the ability to imitate others, demonstration of independently saying no, expression of interest to toilet training, all these desire to please, all these things matter a lot. Otherwise, Neelam said that toilet training, if we go wrong, it is one of the important factors. Before going ahead, at this point, Neelam, I want to ask you that you talked about onset less than 1 year, consider organics, and all of us know that herd spring needs to be ruled out. But would you talk a little bit about cow's milk? How does it also, is it also a contributory factor if I introduce it very early, if I'm not exclusively breastfeeding my baby and introducing cow milk, will it also be a precipitating factor for constipation, especially in the infantile stage?
Right. It's very difficult to say that. That's why in the beginning I said that actually cow milk allergy we talk about into a very small component. But whenever we talk about such things, we overdo things in our country. Like when we talked about milk protein allergy, we overdid it. Initially, we underdid it. So what is very important to understand is that the breast milk water content is pretty high. Like 70% of it is more fluidy than the other milk, animal milk that you talk about. So that is why, since we don't introduce any other liquids to the baby, a mother's milk is most apt. And as Upendra said, we must encourage breastfeeding. And I think IAP is talking about breast banks and all that stuff. That's the way forward rather than going into an animal milk initially.
Yeah, so cow milk has more of, they said, protein to carbohydrate ratio, and also
And
it has
also
slow in the
oat
motility
butter.
also. So try to have that. And of course, one should start with the supplementary complementary feeding from 6 months. That's much better. And wherein we go wrong if we start, the commonest complementary food that is given across the country, everybody is aware of that. It's biscuits. That's number one in our country. So at 6 months, they introduce biscuits, which is full of maida, and all of us know what it can cause. So moving ahead, Neelam, about clinical examination, I come with the history. Is it a must to do a digital examination, per rectal examination?
Yeah,
Do you
so
want all our colleagues to do that?
no, I don't. So
Honestly, otherwise, can it be a clinical diagnosis without doing a PR?
I agree with you. And that's why in my slide, I emphasize that you may not do a rectal examination and all. And I gave scenarios. So there are certain scenarios where either you're suspecting a Hirschsprung's, in that condition, or you've given a treatment, disimpacted, and you still wanted to see how whether the patient is still, there is a relapse and is impacted, then I can understand that you can go about it. But sometimes when we talk about an anteriorly placed anus, or we talk about normal position, and we talk about the anal, so the surgeons are very excited about doing a rectal examination because they want to look how roomy it is, what is the angle, and when you take out your finger, does a gush of stool come out, typically seen in Hirschsprung. Having said that, what Upendra and me are talking about is the word now what is in the majority of the patient, which we don't say organic, but sometimes I really wonder. 2 decades back, when I gave a lecture in Pedicon, or maybe 1.5 decades, 2010 was it, the functional disorders I gave. And I always said that this word functional intrigues me, because what we say is the pain is genuine, the constipation is genuine, but we still call it functional. What we want to say is that we don't understand. So you know how now you're going to see the Rome criteria. So we are not going to use, probably we may throw this word functional also into a dustbin and use the word the gut brain axis, because whatever we are talking about functional till now, we are talking about the dark, the diet, the fluid, the the nerves, the motility. So we're talking about it, we're talking about the stress. So what we want to say is there is no anatomical cause, neurological identifiable cause, no cancerous cause, no
Correct.
inflammatory cause. That's what we mean, because I can see some question in the box, but till today, I mean, we find it easy to describe ourselves as functional because we can't. So those functional cases that are 90%, that's what we are trying to say. You may not jump up to a digital examination. There is much more to it. If it's loud and obvious, a bad toilet training, a fecaloma, fissure and all, how would it be? I mean, then I wouldn't want to do it. I would rather do a perianal examination and all, and limit digital for maybe the
A small
expert.
subset of patients, right? Right. I think moving ahead, the very important point that you brought about, that almost 50% of our dysfunctional voiding is also related to constipation and UTI. So my pediatrician colleagues, I think UTI is another thing apart from constipation all of us need see in practice. So please ensure that not only the bowel is happy, bladder is happy, but the bowel needs to be happy. So that is very important. So we just have to put attention for the child not to be constipated if you want to avoid the frequent episodes of UTI. So moving ahead, Neelap, you talked about polyethylene glycol as a PEG as the treatment of choice. You had no mincing of words there, but we have it in market with electrolytes, without electrolytes. I have per rectal preparation, I have oral preparation. You didn't talk about in the slide. It was mentioned per rectal, not recommended.
It's not we are just talking
Okay.
science. There is today, it's a very typical nothing. So what we talk, the studies haven't shown that there is a significant difference between with or without electrolytes. Only in disimpaction, sometimes people say that if you've used a lot of it and you've had watery diarrhea secondary in that, then maybe the electrolytes they talk. But overall, I don't want to confuse you, and they seem to be pretty okay. And you need to understand what the taste of the patient is, whether they like it whichever way. And the second question you asked me was I don't like to use the anal ones. I just like to use the oral ones. And in the oral, you could have either the same thing in a liquid preparation, or you could have it in a powder form. Both are equally effective, but please understand the basic thing is that what does it do? It's not absorbed. So that's why we say it's safe. So you need some amount of water to be given with it. I've had yesterday a mother where the doctor had prescribed, say, syrup 15 ml, but she went to a chemist and she bought a powder. So she mixed that powder in 15 ml of water. So please explain what rightly Upendra said, that you can use whatever brand you want, know your brand, identify what is the strength in that brand, because different brands have different strengths. Decide with or without electrolytes, and decide whether you want to use a powder or a tasteless or a syrup, and then explain it appropriately to it. Initially, you may want to divide the doses if it's a large amount. Eventually, you can go to once a day dose.
A very practical question Dr. Savita has asked, that she has gone up to 1.5 gram per kilogram of PEG, and still the child has not totally disimpacted. So her question is, should we like at anti-epileptic add on another drug, or withdraw PEG and try something else? So am I allowed to add on lactulose or a Sena or a beta-codil?
Sometimes I would say that this is the time you can involve a specialist with you. And yes, sometimes we like to use a stimulant. And when you use a stimulant, mind you, first of all, two osmotics, they're not too logical. I mean, if you want to combine, you're not going to combine polyethylene glycol with, say, lactulose, or say with milk of whatever. You're not going to combine osmotic. So then you want to use a stimulant, but when you use a stimulant, ensure that you don't go very high on this. Just lower this when you're giving, because at the end of the day, though you say that they are not absorbed, but they do have some side effects. What are those side effects? They could be nausea, they could be abdominal distension, they could be a little cramp. So ensure that you're looking into all that, because when you use stimulant, it moves and there could be pain. So
I think we need to ensure that the compliance is proper.
And sometimes if you talk to the surgeon, one surgeon was, he just was saying, I don't like this gastroenterologist. We're going to do poke a finger and break it and trick it. Give me a break. I really can't do that, except only in a couple of patients like epidermolysis bullosa patients, where they have a lot of anal lesions. Those are the patients who get into disimpaction that you really go in and put it. But for all patients, then yes, I can give enema if it's a very hard stool. Then I can give a suppository or an enema. Sure, in that case, and I would use it.
So continuing the story of which we had started off 1.5 gram per kilogram peg reach, maybe consulted gastroenterologist added on the different class of, not the osmotic one, but maybe a stimulant or something. But is it a point that I have reached the intensified treatment part and now I have no obvious cause of organic? Should I suspect that this child is something different? And this is the point where should I go for anorectal manometry or a motility study, or should I still continue with my therapeutic trial of pharmacological intervention?
Right, good question. So two things. Now, I can just say that somebody who starts the constipation, say at 8-10 years, they're not going to have toilet training issues and they won't have dyssynergia issue unless you find out that there was a sexual abuse and the child had a lot of trauma. So those are the cases that you will go for an anal manometry, because you want to look at the tone and the other factors that you're saying. Otherwise, most of the patients that you would end up is where the onset of age was little earlier, a toddler, a young child. That is where you're talking about these patients that they had. Having said that, any child with psychological impact, the child doesn't want to, he withholds it, then you need those anal manometry with a biofeedback to teach them what I want to say, how to relax and do, like I showed in my case, that I just want to work on them. But I'm not trying to say that all patients where you don't see a response in 3 months, do it. Take an opinion, see, maybe still things are not good. Maybe your diet is not good, liquid is not good. Maybe it's a slow transit. Maybe you want to now look for thyroid or a celiac or a calcium. This is the time that you need to
Yeah, I think dyssynergia is one thing that you really nicely elaborated upon, the paradoxical contraction of pelvic muscles when straining. And of course, you also talked about the internal anal sphincter relaxation when rectal distension. If it doesn't happen, what can happen? So these are the points, and very important, the age group should be kept in mind unless and until something grossly abnormal has happened. Otherwise, a 8 to 10 or 12 to 14-year-old, we need not suspect. But maybe these children who have been not properly toileted in early age group, that's a very nice practical point, whom I should go about being more little aggressive about other investigation modalities. Wonderful point put. And then I would just continue with the fiber part. I think very important. All of us friends from 6 months onward, we recommend about complementary feeding. But regarding this, I have heard people saying, "Pani bahut piyo." Bhai, pani pine se sirf pishab ho jayega. So fluids have not much of role, but it's the complete diet that matters, and half of food plate, that SSS, we always talk about vegetables and fruits and proteins and carbohydrates. Everything is important, and fiber is so important. And unless and until we have our fruits and vegetables, and it is the source, the natural source of our gut microbiota, we cannot neglect it. So all my non-vegetarian eaters also, please make it sure that a green leafy vegetable, a fruity vegetable, and a salad vegetable, all three are extremely important. We need not calculate and tell the patient 5+ age or 8+ age, but have in every meal, the breakfast, lunch, dinner, every meal, we should have good amount of roughage into it. Dr. Seba, you want to have any more questions?
I just want to just add on to it. Sometimes do also see that it's not too much fiber too, because that can also reduce your transit.
Absolutely.
I had a mother who was a very, the hi-fi new smart moms. So she had a child who was 3 years, and she was practically using some 30 grams of fiber a day. So just what Upendra say, that you don't need to calculate, but balance is what he's trying to talk about.
I think somebody has asked about pre and probiotic prescription for constipation. I think then we'll be
if you ask me for evidence-based, yes, I mean, we just started talking about those papers where we are talking about the probiotic use and the prebiotic, but I can't just call it as a recommendation at this age.
Yeah. And Neelam, I would like to know a little bit more about this biofeedback. And you said you have published a paper. I always thought, frankly, honestly, that it was just a theoretical talk and you have good results with that. So let's listen to this practical story about
so
how this
you're going to
biofeedback
give me a
works.
talk in very good. So next Pericon, I'm going to talk about this. Actually, I'm publishing my data on a largest series in India of dyssynergia in children with this biofeedback, 30, 40 patients, where we did show how it does have an impact. And I think it works. And we have to work. It's like, your arm doesn't move. So सारे टाइम में दर्द की दवाई नहीं दूंगी, थोड़ी फिजियोथेरेपी भी करूंगी. So it's something like that. I need to work both.
But you need cooperation of the patient also, the
Well,
family.
very, very good question. Thank you so much. You cannot do it in patients less than 5 years, but a smart 4-year boy who follows your command. That means beta squeeze karo, acha potty karo, kholo. Like, they should follow your command. So you're absolutely right. I can't do it less than 5 years.
Okay. So you ask the patient, you see the factors and you modify those factors. That is how you talk.
So I get a lot of international patients also now coming and, it's peanuts. We just charge very little about it. I think 3,000 per session, something like that. 3.
Per rectal Neelam sulfate with lignocaine or metrogyl with osmotic laxative, does it have any role?
Dr. Ex-President, what is your comments on that?
नहीं, कुछ भी नहीं, उसका ज्यादा रोल नहीं है कुछ. How about picosulfate?
Pico, yes, I do use in as a stimulant, but it helps to move it. So as a combination of that thing, you can use picosulfate, but not too long. But yes, you definitely, there are some patients who won't respond to osmotic and you may need to use.
Yeah, Siba, you had some question?
Basically, how many, what is the prevalence of the dyssynergia in clinical practice? Basically, in many centers, we are not doing the manometry and everything. So, actually, how many, what is the prevalence?
First of all, this is a new development, like 5 years before, where did I talk about it? So please understand that things are changing. That's why the title was What's New. Did I ever talk about all this earlier before 5 years? So neurogastroenterology is a new department, and we formed one of the first neurogastroenterology department in the private sector. I'm sure there are many centers that are doing it, but you can't expect every center to start doing neurogastroenterology work because it's a very dedicated thing. You need the gastroenterologist, like the number of hours that they need to spend on it is a lot. So we have like a autism gut clinic, or we have this neurogastroenterology clinic, the food allergy clinic. So these are very dedicated clinics. Only one person cannot do everything. If you expect me to be doing anal manometry for 45 minutes and spending 2 hours on a biofeedback, I need different consultants to do that. So you need to understand that everybody need to identify, and it's a multidisciplinary team. And that's what I started. And I did mention that I'm very impressed with somebody who gave me a talk, what's new Rome 5. So it's not come, but we are talking, what's my thoughts about it. So this is what we are saying, that neurogastroenterology, and what talk I gave in 2010 Pedicon is when I said, I'm not sure what this functional is. Maybe before I retire, the term functional may go off to where we are saying. So as our understanding increases, the idiosyncratic or the idiopathic group decreases.
Yeah. Neelam, is there any difference between a non-retentive and retentive incontinence? Because constipation causes a little bit of fecal incontinence, but can I differentiate clinically between these two?
Excellent question. So what he's asking me is, that imagine I gave you that this is the rectum and this is the anal sphincter. So for whatever reason, your anal sphincter is not relaxing or closing, and this rectum, it goes on getting wider and wider with the stool. So it absorbs more water, it gets harder. Because it gets harder, it can't come out. It's like a delivery. Please imagine what I'm saying. So it can't come out. So it's going to be hard there. So the liquid part of the stool is going to come from the sides on that. So that is called as fecal soiling. And that's what Upendra says, retention of the stool with incontinence. तो आपको पेशेंट क्या बोलेंगे, पतली टट्टी हो रही है, and but don't overdo it. Then you will be able to feel the lump clinically in the part just above your pubis. There, if you palpate, unless the patient is obese. So in the obese, that's why I said in obese, I do an X-ray. I talked about an X-ray role in obese. Because in obese, you may not be able to do a lump palpable or a PR. In that case, you would need it. And that is the time you want to know, is there any impaction with the liquid stool or it's just a liquid stool?
Correct. Neelam, Dr. Sonia has said she has appreciated the talk, and she says just one question. Is anal manometry available easily everywhere in the country, or where it is? And what's the cost? Is it extremely discomforting and painful to the child?
No, that's what you think the kids would do with me. I mean, 2 years, 3 years, 4 years, 5 years, yeah. So, and in the smaller babies, if you just want to rule out rare is to rule out hush sprungs, I can put them to sleep. Because what is this? Sympathetic, parasympathetic. If this opens, they should contract. It's not voluntary. So in the smaller babies, where I'm not expecting dysenergy, I can put them to sleep and look for it. But in those babies, it's not painful. It's like thin catheter. But of course, as I said, even putting a cannula, you just can't hold a baby and you need to talk. So that is why
that's typical of our pediatric branch itself for everything. It takes
time. You need, sometimes that's what this field is all about. That. And Absolutely. That's you need a dedicated neurogastroenterology clinic to look into that. And the cost is not high for an anal manometry, something like 8-ish, 7-8-ish we charge, and that's like an hour procedure, which includes everything.
So most of the tertiary care centers have it across the country?
I think so. Now, see, where a center where there is a single person cannot have it. It's not possible for anybody and everybody to do everything. I mean, mostly, I'm not saying addictive. If you're busy, if you're not very busy and you have limited patient, then you are able to do everything. Once you start getting busier, then you need a team to look into this, to look into your endoscopies, liver work, transplant, biopsies, endoscopies, all that. So identify a center which is doing it, because these machines are expensive. They need training. And if you don't have the training and you do a wrong thing, I tell you, you don't have your nerve. Imagine how would, the mother feel if it is a wrong thing. So it's not the cost, it's the expertise that is there, and it's just developing across the country. And don't misunderstand me, but the title, I had to justify what's new, so I'm doing.
That was important to understand.
I'm not trying to sell it, but I'm saying that there are certain new blocks on the horizon, which you need to know. That's what I meant.
Yeah, absolutely right. I think Dr. Dilip Pawar has asked how to introduce fiber in a 7-month-old child's diet. So we talk about vegetables and fruits. So fruits, very easily we can give, now current season of mangoes, papayas, bananas, you can give the pulp of fruits very easily, just mash it. No need of boiling everything. And vegetables, I think you can always, dal chawal, if you're making a khichdi, you can always boil the tomato, carrot, and put the vegetable. The point is, let child be introduced to all the vegetables and fruits. And as the age advances, you can do the finger foods, the chopped foods, and the child should be encouraged to have self-feeding. That is what matters when you're doing complement.
To know that pulses, dal, have high fiber.
And Dr. Mazumdar has asked how to treat diarrhea-like episode due to chronic constipation. She has already elaborated much about it before your question was asked. We were just discussing about the same thing, how chronic constipation can fool you, and the patient may present just as diarrhea, but which is actually, when you go into the details and as she showed, that the upper part may be actually holding a lot of fecal mass, and then the fluid just oozes out of it, and spurious diarrhea, as we may call it. I think that was wonderful. Any more questions? I think that was great learning
It was
experience for me
my
too.
privilege to have a moderator, a rocking moderator like Upendra. Teachers or Upendra?
No, it's okay. I think we have two more experts. Anupam, may I invite sirs, both of them, to be
Yes,
here?
please, the experts, please.
Sir, we also have Dr. Shyam Sundar Meena, who is DM Hepatology and Gastrology from PGI.
Sir,
Yeah,
please,
may I invite him for
expert
some
comments, Dr.
expert?
Meena ji.
मीना आपको
Hi.
अनम्यूट करिए.
Hello, Meena ji.
Hello, thank you, ma'am.
Nice. So nice to see you, Meena.
So
Good
nicely,
evening.
along with the Dr. Upender, most of the issues as
थोड़ा सा उसको दूर रखो, आपकी शक्ल थोड़ा सा दूर कर. That's perfect.
to nicely cover the most of the things for the benefit of the general pediatrician. I think majority of the difficulties that dealing for the constitution patient you already covered. My message to for the general pediatrician, majority of the time you should spend the most of the time for taking the detailed history. Because we are the too hurry to when just parents say the child is not passing the stool, we just hurry to prescribe the medicine. But you should take the detailed history to rule out the other organic causes, or like the Dr. Upender says, many patients come with the spurious diarrheas. And I day-to-day practice, I seen the many patients getting the zinc ORS for the parents say the child passing the frequent stool, but that is not actually diarrhea. That is a fecal incontinence due to the retentive issues. So we should take the detailed history. Second thing, during the treatment, that I usually use the triple D therapy. D means one of the drugs. Second, diet. Third one is discipline. So drug is one of the important supportive treatment therapy, but it is just for the time being. So we should spend the maximum time for counseling of the diet. That is very important thing. Regarding the fibers, that is a important thing to manage the constipation, especially functional constipation. Along that, third D is a discipline, because nowadays majority of the children are using the indoor games, and they are the maximum time spending on the screening time. That is one of the important trigger or leading factor for the constipation. So we should motivate the children during our counseling to use the outdoor games and participate in the outdoor activities. That is important thing. And one of the someone raised the question regarding the what happened where the patient is not responding with the PEG. So when you are taking the detailed history, you should rule out the retentive incontinence, because majority of the children are easily mostly responsive to laxative, but those are the children having the retentive issues. They are not easily responsive like any laxative. In that, children might be required the stimulant laxative like the sodium picosulfate or etc. for the short period, like as you rightly said, 3-4 days, 5 days, 6 days. Then PEG is automatically work for that. So that is very important thing. And now, because today's talk is constipation, newer things. So newer is nothing that's change in the definition in the ROM 4 criteria, like they are the duration initially required in the ROM 3 is 2 months. Nowadays we use only 4 weeks. And second, nowadays coming some of the newer modalities, not for the general pediatrician, but now they should be aware if the child is not responding to like the laxative like the polyethylene glycol for the at least 3 to 4 week, or then in that situation I feel they should be hand over the patient to specialist like the gastroenterologist, because a lot of the other things like the prokinetic drugs, secretogenics are available in some of the refractory constipation cases that work nicely. Thank you.
Thank you, Dr. Meena. I think you have answered one more question which was asked here. Any evidence of exercise on constipation? Yes, there are a number of papers published. We need to be physically active also. So very, very important factor. Thanks for bringing that out.
Very good point. 4 Ds.
Yeah. And Dr. Savita has asked Neelam that when ये lazy bowel की बात हम करते हैं, stretching हो जाता है, और accommodate करता जाता है, brain भी respond नहीं करता है. You have given good treatment. How long does it take to come back to normal? Does bowel come back to normal? And what end point should be the treatment?
See, what you need to understand is your bowel is like a balloon. So if it comes back, if you blow it and just remove it, it will come back quickly. But if it's being chronically constipated for, say, months to years, then you can't expect it to be, quickly. So there is no thermometer that I can have to say that it takes this weeks or this month. But in general, what people say is that it takes time for the bubble to come. But please, what I'm trying to say is we get stuck with some cases, which are the transit studies, which I said specialized, and I didn't talk about it. I said the EMG, the MR, and the transit, and all. These are the cases where we want to get stuck and we want to identify what else is happening. There are cases in the world, if you see, that what they do is they put up the appendix outside to your skin, and actually you're expected to do flush outs. So you are desperate because the movement of the colon is so bad, and it's like a thick loose colon, that it takes time. So then they do that and they do the flushes till the colon takes time or the nerves regenerate. Because sometimes, very good question you asked me, sometimes post viral or post some drugs or something, say your nerves got damaged, and then they may take time to regenerate, to recover, and that is when it can take time post an illness.
Yeah, perfect. Very well said. I think it will take time, but then we must ensure, and spending time with, as Dr. Meena said, spend time
Unless
with the family.
it's a
It is not overnight.
pseudo-intestinal obstruction with motility disorder. So those are the experts. Motility won't change.
Don't expect a overnight miracle even in a normal day-to-day functional constipation. So talking to the parents is so important, and to the child also. So all in all, a great session. Thank you so much. Great take homes. Red flags, we won't forget them. The treatment, the diet part, the counseling part, and when to stop and take help of our pediatric gastroenterologist colleagues. All points very well elaborated. Thank you so much. Back to IAP Delhi. Thank you.
Right, sir. So it was pleasure talking to have a kind of inspirational, motivational talk from Dr. Neelam Mohan, and vital inputs from Dr. Shyam Sundar Meena, a dear colleague of mine. So we also have our Central IAP EBs from Delhi, Dr. Lalit, Dr. Kaushal. Sir, would you like to say something? Dr. Lalit and Dr. Kaushal, sir?
Very nice interaction between a moderate and a wonderful speaker. Neelam has always been a wonderful speaker. Starting from basic, you have come to the latest. I have just one thing in mind, what is the impact, long-term impact of functional constipation in early childhood? Do they have some cognitive dysfunctions later on? And what is the impact on the adult onset constipation? Is there anything related to that? The childhood constipation continues to adult, and what about any cognitive effect? You are discussing that there is definitely a neuroendocrine axis working. So is the impact going to last long, or we are going to have some long-term impacts of the functional constipation in children?
Yeah.
And one simple thing, below 1 year, you said you cannot use the poly-EEG, because we see infants also, breastfeed infants, and the child is having constipation. They may not follow all the criteria, but sometimes the constipation is very troublesome. So just these are the two small points.
Right. So the second point is, if it starts early, you should think about organic constipation too. Second, if there's been a faulty feeding in the diet, that it can give rise. Third, it could be due to the organic causes that you need to look out into it. And the definition is that even if 2 stools in a week, but they are not difficult, hard, etc., not discomforting, then that's okay. It's not the frequency. That was the second part. Coming to the first question, very interesting question. So please understand that what we are saying, even in the functional constipation group, is that it's not nothing. We are saying that there is an intentional withholding. Either there is a luminal cause, which is your diet, or there is a motility, which is a slow transit, or there's a dyssynergia. So suppose if there is a motility issue, it can go on for long. I remember as a child, I mean, my own case, that I've been constipated right from school days, and I still am. So there is going to be a slow transit. So those people may not just do it. So whenever people have something to do with their transit, they have to be extraordinarily careful with the activity, with the gut microbiota, which is resulting from the diet, from the sleep, from the stress, from all these are the factors which affect and will have a ek aur ek 11 rather than ek aur ek 2. So that is what it can have, just like in a reflux disease patient. We say that 90% grow out or 85% grow by 5 years and then they grow. But some of them continue to be reflux long time. If they have a patulus or a hiatus, they may not get okay. Similarly, if you may see patients who have reflux and constipation. So these are those motility patients. They have a higher chances of reflux. They have a higher chances of constipation. So they may go on in life. And cognitive, who knows better than me, Lalit, and he's smart to ask that question because he always says that the impact of a trauma, the mental trauma, the physical that can give rise to it, to the abuse, the physical or the emotional abuse that the child can have, can impact the development of a child and have its repercussions. And that's why I said constipation is a Pandora and not just a heart stroke.
Dr. Kaushal?
Yeah, very good evening, ma'am. As expected, a well-delivered talk full of key messages and equally well supported by Dr. Upendra. Well moderated, sir. Very good evening. And I think talk is absolutely clear about what a general pediatrician, till what point they should attempt. And there are a number of new things are also available, which are in the preview of gastroenterologist. And at least the parents can get the answer what actually is going on with the child as the science is expanding. Madam said that something which is idiopathic today maybe become a known thing tomorrow. So well attempted, ma'am. Thank you very much.
Thank you so much, Kaushal.
Right, sir. Sir, we also have a senior pediatrician, EB from Central Delhi, in Central IAP, Dr. Lalan Bharti, and our President-elect, Dr. Pankaj Garg, sir. Sir, would you like to say something, Dr. Lalan, Dr. Pankaj?
डॉक्टर पंकज का एक क्वेश्चन भी आना आंसर्ड है अभी वैसे.
डॉक्टर पंकज, डॉक्टर ललन भारती. राइट सर. सर
नेक्स्ट टाइम के लिए रख लेते हैं.
राइट सर. सर अनुपम सर, कैन वी वाइंड अप सर?
Yeah, thank you very much, everybody, especially Upendra for being a great moderator, and Dr. Biswal for being there with us for such a long time and participating fully. Of course, don't want to undermine the contribution of Mukesh, Alok Bhandari, and Shyam Sundar Meena and Lalit Mandiratha. And all said and done, the adhesive, the binding force, Neelam Mohan, who was the person who held the whole talk together and made it so interesting. Thank you very much, all of you. And we hope to have such good, brilliant sessions again and again every Thursday between 8 and 9 p.m. Good night, everybody.
Right.
You deserve a special applause, sir. इतना बांध के रखा हुआ है, and you're giving very good science to all of us. Thank you.
Thank you very much, sir. Thank you.
Right.
Bye-bye. Thank you for mentoring. Thank you so much.
Bye-bye, everyone.
Bye.